Welcome to our today's webinar on HIFU treatment for liver and pancreatic cancer. And I'm very glad to have these highly renowned experts on the panel and as reference for the interesting lectures. So I think I first should introduce Professor David Cranston, who is I hope he will hear me. He's my co-chair.
Yes, I can hear you.
I think it's not really necessary to introduce him, but he's the Associate Professor of Surgery in the Nuffield Department of Surgical Sciences, the University of Oxford, and Honorary Consultant, Urological Surgeon in Oxford University Hospital Foundation Trust. And he qualified from Bristol University in 1975 and worked in Exeter and Bath before moving to Oxford. His special interest is in renal surgery and was awarded his PhD in 1986 for kidney transplantation-based research. He is author of more than 100 peer-reviewed publications and 5 books, including 3 on various aspects of the history of medicine. Since 2001, that is for more than 20 years, he now has been clinical director of the high-intensity focused ultrasound unit in Oxford, which with colleagues in the UK and China is researching into a novel way of treating cancer without surgery. He has co-supervised 20 research fellows for higher degrees. He was elected a governing body fellow of Queen Templeton College, Oxford in 2006. So by this, I can give the microphone over to David.
Yeah, thank you very much. And let me introduce Professor Strunk, who, again, I'm sure needs very little introduction. He is Professor of Radiology in the University of Bonn, and together with Dr. Marinova, established and operated the first HIFU department for the treatment of non-operable pancreatic tumors in German-speaking countries at the University of Bonn. And his principal areas of interest and expertise are HIFU, ultrasonography, and interventional radiography. And presently he works as chief physician in the Department of Diagnostics and Interventional Radiology at the Municipal Clinic of Solingen. And so I think it's up to me to introduce the first speaker, who is Professor Zhang Lian, who has been a good friend and colleague for a number of years whenever I'm in China. So he is director of the Chongqing HIFU Hospital and chief editorial board member of the International Journal of Hypothermia, as you can read on the slide, and professor at the Key State Laboratory of Ultrasound Engineering in Medicine, co-founded by the Ministry of Science and Technology in Chongqing Medical University, where he's a professor. And he had first class in the Science and Technology Progress Award in China in 2009, and second class of the National Science and Technology Progress Award of China in 2010. And he's published more than 80 papers in international and domestic journals and more than 100 other scientific papers. The highest impact of a single paper was nearly 17. And he is going to talk about the clinical experience of HIFU on liver and pancreas cancers in China. So thanks very much, Professor Zhang Lian. I'll hand over to you.
Thanks, David, and good morning, my friends. So it's my great honor to be here and have this chance to share the experience of HIFU treatment for liver and pancreatic cancer. Can you hear my slide?
Yep.
Yes, high-intensity focused ultrasound is a non-invasive treatment modality. So here is a slide, shows how it works. This is a transducer. The ultrasound beams were generated from this surface of this transducer and just focused at a very tiny point. During the treatment, the ultrasound beams penetrate the human body and just focused at the target tumor. When the temperature increased to over 65 degrees, necrosis occurred. From the monitoring image, monitor ultrasound, we can see the grayscale changes like this. So when we see the grayscale changes like this, it means the water is boiling. It means the tumor is, the necrosis is occurred. So now I can show you how did we do the treatment. For example, this is the liver. So first we start from here and we solicate. Then we can see the grayscale changes like this. Then we move the focus to the another point, just like here. Then we solicate again. Then we see the grayscale changes. Then we move down to this point and solicate like this. So when we see the grayscale changes, area cover the whole tumor, then the treatment is completed. So it's very simple. So this is how did we do. So first I want to talk about the HIFU treatment for liver cancer. As we know that we have so many ways can be used to treat the liver cancer. HIFU, of course, is one of these modalities. So in 2013, the FAST Foundation organized a meeting, a group meeting in Heidelberg, Germany. In this meeting, we reached a technical and clinical consensus. In this review, we can say we all agree with that. So far, the ultrasound-guided HIFU, the GSM model, remains the only system can be used to treat the liver cancer. So for the liver cancer, HIFU can be used for not only for palliative treatment purpose, also can be used for the curative treatment purpose. So first, I show you the HIFU treatment for small HCC. So in China, of course, for small HCC, the treatment of choice is surgery. So only when the patients were not indicated for surgery, or they are not indicated for RFA, or they don't want to go for this kind of treatment, then they come to us for HIFU treatment. So for the small HCC, in this study, we just like if the solitary tumor should be smaller than 5 centimeters in diameter, or if the number should be less than 3, with each tumor smaller than 3 centimeters in diameter. So this is a study at the beginning we did. So total 35 cases, and here the baseline characteristics of these patients. So we can say most of them had just one lesion, and so most of them at a stage 2. So after HIFU treatment, we follow up these patients. The 5-year survival is around 17%, which is very good. So here we can say how the procedure. So this is the lesion, just 4 centimeters in diameter. So we start to treat this lesion. Also from the ultrasound, we can say this patient had ascites and the cirrhosis is severe. So no chance for surgery. So we treat this case from 2 p.m. Then you can see the grayscale changes like this. Totally 30 minutes, we finished this treatment, and we can see the grayscale changed area was larger than the tumor size. So, which is very good because for the curative treatment purpose. So generally, the treatment, the room time for the small HCC is around 2 hours. So this most important for this kind of case, like the lesions located in difficult locations, like HIFU can be used for the palliative treatment, also for curative treatment purpose. So now I'm going to show you for the small HCC. Can you? Yeah, so in China, like you already knew about that. So for the small HCC, the treatment of choice always go to surgery. So in our center, like if the patient come to me with a small HCC, they are not indicated for surgery, or they are not, they don't want to have go to surgery, or they are not indicated for RFA, or they don't want to go to for RFA. So in this study, like we enrolled 35 patients, like this is the baseline characteristics. Like you can see, all these patients, like the size, the average size is around 4 centimeters, and most of them at the stage 2. So we performed the HIFU treatment. The follow-up results shows the 5-year survival rate is around 70%. So like this is comparable with the treatment like the surgery results. So for the treatment, it's very simple. Like this case, this patient had a cirrhosis, and also from the ultrasound, we can see still some ascites there. Here is this lesion is around 4 centimeters in diameter. So we treat this one at the 2 p.m. Then totally 35 minutes, and you can see the gradual change the area to cover the whole tumor. The treatment area was larger than the tumor size. So for the curative treatment purpose. So like this one, the lesion is located in difficult locations. The patient had RFA before, but only ablated small part of the lesion. So the patient came to our center, then we treated this patient with HIFU. So this is contrast ultrasound shows the lung perfusion area. So one day after that, the CT scan showed the treated area. There was the tumor was completely ablated. Here is 1 month, and this is 3 months after that, the tumor was getting smaller, no recurrence, and low residual tumor in there. So this is an old case, and probably you already saw this before. This patient had a surgery, had a surgical resection for HCC before, but later there was a new lesion there. So the patient didn't want to go to the surgery, so came to our center. Then we treat this patient. MRI shows 3 months after that, the treated region was much smaller than before, and you can see there was low enhancement. We can still see the surgical scar there, but the tumor was getting smaller. 19 months after that, there was low lesion, disappeared after that. The 2 years after that, no recurrence. Then this means still, like I said, curative treatment purpose. So let's go to the other one. And so, like we knew that most of the patients with the diagnosis was made, they were at advanced stage. So for this patient, this kind of patients, so usually we refer them to go to TIE for transcatheter arterial embolization first. But unfortunately, around 17 to 18% of the patients after TACE, they still have the residual tumor there. So just like this case, we can say this patient had a TIE first, but we saw the enhancement in the tumor. So only part of the lesion necrosis there. So for this one, we should go to perform HIFU treatment for this kind of case. So you can compare. That's completely different. So that's what we do. So after TACE, if the patient, the lesion was unblessed, then we just leave it alone. If we found some residual tumor, then we go to have HIFU treatment. So we compare two groups of these patients. So you can see from next slide, then this is the baseline characteristics before treatment. So you can see no significant difference between the two groups. So after treatment, we follow up the patients at different. Next, Jenny. And you can see the survival rate at different follow-up time. After PACE, we gave the HIFU treatment, the survival rate was much higher than those groups just treated with TAE alone. So I think this is very good opportunity for the patients if they don't have other choice. Next. So this is a case like we treated a long time ago. This patient's the lesion was 14 centimeters in diameter. So this patient had diabetes and hypertension. She didn't have the chance. She was not indicated for surgery. Then this patient went to have the TAE first. Then we treated this patient with HIFU. So you can see the follow-up image. So different time, 4 years later, you can see the treated region was much smaller. There was low recurrence. So the patient still alive. So for this kind of patients, HIFU offer them another option. So except HCC, for liver metastasis, HIFU actually is more sensitive. It's easier to treat liver metastasis than HCC. So here, I just want to show you 82 cases, like the tumor number enrolled in this study, like the number should be less than 3. So in this, among the 82 patients, 28 patients had 1 lesion, 15 patients had 2, and 39 patients had 3. So the average size was 6 centimeters in diameter. So all of these patients not indicated for surgery, not indicated for RFA, or they don't want to have this kind of treatment. So they came to us, we treat with HIFU. So among them, 22 of the 82 patients had previous surgery, and 30 had PACE before HIFU treatment. Or the total number of the lesions, we treated 175, but around 19% of the lesions had been completely ablated, and 18 of the lesions had a partially ablation. So about the edema and about the complication, we don't have major complications in these patients. Only 16 patients had local edema. So all of these patients had image evaluation after HIFU treatment, CT, MRI, or PET, or ultrasound. So for the overall response rate was very good. So here is just some examples, some cases like this case, this lesion, this patient had colon cancer and had liver metastasis located adjacent to the IVC. Here's the portal vein. So we no other choice. So we treated this case. We just put the focus right there. You can see the grayscale changes. It's very easy. So just we recorded the grayscale changes area. So after that, this here's before the PET scan shows the lesion right there. So 3 weeks later, the PET scan shows the tumor was the lesion was completely ablated. So the total solidification time is 13 minutes. So which is very good, very sensitive. Next. So here is another case like this patient also had a colon cancer. Then the lesion, liver metastasis just located segment 1. So we knew that there was no other choice. So we treated this with HIFU. So the total solidification time was 33 minutes. So 1 day after that, the CT scan shows we this is the treated region, no enhancement in this area, no perfusion. So the treated area was much larger than the tumor size because for the curative treatment purpose. So the good thing you can see the IVC, the portal vein, so low damage. So 31 months after that, you can see the treated region, the tumor was getting smaller, and we consider the perfusion of the major blood vessels. And here 3 months and 8 months, 2 years and 3 years. So almost disappeared after 3 years. So except for primary liver cancer and liver metastasis, and we also use this for the cholangiocarcinoma for those who are no chance for surgery, or they are not indicated, or they are not no response to chemo. So we can use this one to treat HIFU, to treat this kind of patients for palliative treatment purpose. Since the cholangiocarcinoma, the blood supply is poor in both of the lesions, so also it's very sensitive. So next. So we can say, like this case, this patient was very young, just 37 years old. 2014, he was diagnosed with cholangiocarcinoma. The CA19 was very high, and he was giving chemotherapy. The tumor marker decreased, but 3 years later, the tumor marker increased again and low response to chemo. So we decided to treat these patients with HIFU, then give chemo again. So here is the lesion. We can see multiple lesions. This largest one was the size was larger than 10 centimeters. So we treated this case. The treatment time was not so long. So we can see the next slide. Next. So here, like the left lobe of the liver, we can see the grayscale changes area, just like this. Here is stomach. So the total solidification time, just like 1 hour. So, and the power we use 400 watts, the total energy. So the response was very good. So let's say the follow-up image next. So this before, here is after that. So we can see the most of the tumor was ablated, the tumor was treated. So after treatment, the tumor mark decrease again, then we give the chemo. So the patient benefit for this kind of treatment. Next. Here is another case. This patient was 17 years old, diagnosed with cholangiocarcinoma. So you can see the lesion over there is around 7 centimeters in diameter. Here is this before, we can see the perfusion of the lesion. And here's after that. So the total solidification time is 3,000 seconds. So here's 8 months after that was getting smaller. So for these patients, I think HIFU can also help these patients. So for the liver cancer, I can conclude that HIFU can be used for the curative treatment purpose, also palliative treatment purpose. To the patients can benefit from HIFU treatment. So here is about the liver. Now I'm going to share with you guys about the pancreatic cancer, the experience from China. So we started to use HIFU to treat pancreatic cancer in 20 years ago. So at the old days, then we can see like this 25 cases. Next. So at that time, so the effective rate was not as high as right now. Like Holger already showed us, like the pain relief, almost 100%. So at that time, like around 70% like that. Also, MRI shows like the local tumor control was good. So next. So here is about the tumor volume. We had 4 patients had a tumor disappeared, and 8 of them had Schematic, and 10 of them had stable. So local control was good. The effective rate around 90%. For the tumor marker, 92% of the patients had a tumor marker decreased. So which was good, even at the early stage. So now I think it's different. Here is a table I summarize like different center, different country. They use this technique to treat the patient with pancreatic cancer, like from Korea 2004. At that time, after their patients, like the median survival time is around 1 year, like the for stage 3 and for stage 4. The pain relief is 100%. They reported also in Milan, like Franco Ossi from his center is a similar result like the Korea did at that time, also Bulgaria and also Spain. But now, like from Holger from Germany, they had better results now also in China. I think this patient, we have the better results right now, probably one because of this technique, another one also, I think they like the chemo. The development of the chemo also helps this kind of patients. So I think in the future, probably we need organize a multiple center studies to compare like the chemo and between chemo and chemo with chemo plus HIFU. So I think this future we should do. So I also just want to show you some cases. Next. So like this case, this patient had a pancreatic cancer over there. The celiac trunk was surrounded by the tumors. No other choice. So for this one, we treated with HIFU. The solution time is 21 minutes. So CT scan shows 14 months after that, the treated region was getting smaller. The blood vessels, low damage. I think is very good for this one. So this patient, like after treatment, the pain disappeared. Local control was very good. The patient died 2 years after HIFU treatment. So I believe she benefit from this treatment. So next. Jenny, next. So for the like the pancreatic cancer at the head of the pancreas, we use a like metallic stent. So like Holger said, plastic stent, but most of our patients use a metallic stent. So because we just don't take the chance, so we usually just like this. But it's okay, either plastic or metallic. But we can, after that, we can treat the patient safely. So here's CT scan shows 1 day after that, the treated region. So then we can see the stent over there, but low damage to the surrounding structures. Here's 3 months after that, we can see the treated region was getting smaller. PET scan shows no recurrence in the treated region. Next. So this case actually we treated last year. This patient was very young, just 44 years old. He had a pancreatic cancer here, but also had a liver metastasis. So for this one, we treat the tumor here. Then we follow up this one. Then you can see 3 months after that, almost was disappeared, was getting smaller. Also next, for the liver metastasis, here's before treatment. You can see multiple lesions over there. Also, we treated this one, and after that, gave chemo. And after that, 3 months after that, also the small lesions was getting smaller. So I think for the pancreatic cancer, a HIFU treatment is really a good choice for them. So according to our experience, ultrasound-guided HIFU could be considered as safe and effective approach for treating pancreatic cancer. So in the future, like I think we would like to work together to do some clinical study to confirm the to confirm the role of HIFU in the treatment of pancreatic cancer. So that's all I want to share with you. And also, I hope see you guys soon in China, in Chongqing. Thank you very much.
Thank you very much. So again, if you stop sharing the screen, or can see if there are any questions, or you can put them in the chats.
Dear ladies and gentlemen, dear colleagues, I first have to apologize. To my deepest regret, my highly esteemed colleague, Milka Marinova, cannot attend this webinar. Therefore, it will be my part to give you a lecture on HIFU therapy in pancreatic cancer. We are pleased to have the opportunity to report our results in the following minutes. Only adults with histologically or clinically diagnosed unresectable pancreatic cancer were treated. Methodologically, the tumor diameter had to be greater than 2 centimeters, and all patients had tumor growth or marked tumor-related pain. Of course, the tumor had to be visible by sonography, and the distance between the skin surface and the deepest tumor region should not exceed 11 centimeters. Therapy was not considered in children and adolescents, in patients with an ECOG status greater than 2, and those in whom surgical resection was potentially an option, or in whom the tumor could not be visualized by sonography. Theoretically, we would also not have treated patients in whom general anesthesia was not possible, but this was never the case. Accordingly, you can see from the following table that of 133 patients who presented to us with the question of possible HIFU treatment, only 80, or about 60%, were considered for HIFU therapy. In 25 of the excluded 53 patients, the tumor stage was too pronounced, and in 9, the general condition was so poor that local ablative therapy was no longer considered reasonable. Only in 8 patients was the tumor sonographically not visible. Let me show a few examples in the following. Here's a patient who, despite liver metastasis, had only an approximately 2 centimeter tumor in the pancreatic corpus, in whom, for methodological reasons, HIFU therapy was not an option. Here's another patient in whom the pancreatic corpus carcinoma would have been treated by HIFU, but whose metastases were so extensive that local treatment of the pancreatic tumor was not considered useful. In this patient, the tumor located in the transition area from the pancreatic corpus to the pancreatic tail could not be visualized sonographically, despite compression and preparatory measures. The same was true for this patient with a pancreatic tail carcinoma located in the splenic hilus. This was complicated by the fact that the distance between the skin surface and the tumor was 14 centimeters. In this patient, too, the tumor marked with an arrow could not be visualized sonographically due to obesity and the very great depth of the tumor. For clarification, the distance between skin surface and tumor is shown here. This was 22 centimeters. It was also necessary to exclude patients who had metal clips in the area to be treated after previous surgical interventions, or who had pronounced calcifications, as shown here in the patient on the right side. Both with metal clips and with pronounced calcifications, there is a risk of unpredictable sound scattering and sound amplification with a risk that cannot be calculated. In the meantime, we have treated 170 patients in Bonn, 82 men, 88 women. The mean age was 64 years. The youngest patient was 28, the oldest 89 years. Only 3 patients had a tumor confined to the pancreas. In all cases, a locally infiltrating or metastatic carcinoma was present. Most patients were found to be in ECOG stage 1 or 2. We were also able to perform HIFU therapy in patients with biliary drainage, and thus 23 of the treated patients had a metal stent and 19 had a plastic stent in the extrahepatic bile ducts. A second HIFU treatment for local tumor progression was performed in 14 patients. As indicated, virtually all patients were symptomatic. This is shown in this table of our first 10 patients treated. As you can see, all reported pain and most also reported weight loss. In addition, most had local tumor growth despite chemotherapy. This illustration shows a schematic drawing of the ultrasound-guided HIFU unit used. Patients were positioned prone on the treatment table. In this treatment table, there is an opening with a water vessel. The patient must be positioned so that the skin over the organ to be treated is at the level of this opening, and thus the skin is in contact with the water. The parabolic therapeutic transducer with the convex diagnostic ultrasound probe in the center is located in this water vessel. The therapeutic ultrasound beam was transmitted by 20 centimeter diameter ceramic transducer with a focal length of 15 centimeters, operated at a frequency of 0.8 megahertz. To compress the stomach and dislocate the bowel away from the acoustic path, a balloon filled with degazed water is positioned between the transducer and the skin or the anterior abdominal wall. During the HIFU procedure, the extracorporeal therapeutic transducer generates an ultrasound beam forming an oval-shaped focus-sized 1 to 3 millimeters in width and 8 to 15 millimeters in length. This slide demonstrates operators' real-time view during the ultrasound-guided HIFU ablation of the pancreatic cancer. A, indicate the diagnostic ultrasound probe, B, the water basin, with a water-filled balloon between the patient's skin and the probe to improve the acoustic window. C, the anterior abdominal wall and patient's skin in contact to the water and water-filled balloon in prone position. D, this green cigar. The cigar formed a focus within the hypoechoic pancreatic tumor generated by the therapeutic transducer. The green cone here and the blue triangle up here show the acoustic pathway of the ultrasound beams. Using the auxiliary software, fusion of real-time ultrasound images with CT or MRI images obtained prior to the HIFU treatment can be displayed. The figure shows CT images fused by the software during HIFU. The current ultrasound image of the HIFU device and the calculated projection of the therapeutic ultrasound beam on the CT image are displayed. The focal zone is shown as an oval cigar-shaped area in the tumor. Although this is a nice option, in practice it is rarely needed. Treatment time averaged a little less than 2 hours, but ranged from about 1 hour to about 4 hours. Pure sonication time averaged about 900 seconds, and the applied energy was 330,000 joules. This illustration shows images of a 78-year-old male patient with inoperable cancer of the pancreatic head within the cystically transformed pancreas and enclosed percutaneous transhepatic cholangiography and drainage, treated with HIFU. White arrowheads on these transverse contrast-enhanced MRI images indicate the tumor before and after HIFU. Shown here are coronal contrast-enhanced MRI images before and after HIFU, as well as coronal T2-weighted MRI images before and after HIFU. Please let me now present our results. The main indication of our treatment was, as already indicated, symptom relief, especially improvement of the pain reported by most patients, as well as improvement of the quality of life. Also important, but not the primary goal, was of course local tumor control and the hope for prolonged patient survival. Let me first talk about the main indications. Pain relief after HIFU treatment was evaluated with the pain score of the European Organization for Research and Treatment of Cancer Quality of Life questionnaire. Significant pain reduction was observed over time. The pain relief occurred directly to 1 week after HIFU therapy. This effect persisted over time and even improved at 3 months follow-up. Also, significant improvement on the quality of life scales of the EORTC questionnaire over time in patients with locally advanced or metastatic pancreatic cancer who underwent at least one follow-up examination after HIFU treatment. The functional improvements were accompanied by significant reduction of tumor volume after HIFU therapy. Volume reduction 6 weeks and 3 months after HIFU treatment compared to baseline in percent are shown here. A 54-year-old female patient with locally advanced hepatic and pulmonary metastatic pancreatic corpus tail carcinoma and marked opioid-dependent tumor pain was treated with HIFU in addition to gemcitabine chemotherapy. No pain medication was required 6 weeks after HIFU. Shown here are axial and coronal contrast-enhanced MRI images of a pancreatic tumor before HIFU, immediately after HIFU, demonstrating no contrast enhancement in the treated tumor sections, indicative of effective ablation. The tumor volume reduction was 29% and 66% respectively 6 weeks and 3 months after HIFU. Shown here is a 56-year-old male patient with non-resectable locally advanced adenocarcinoma of the pancreatic head and corpus and significant cancer-related pain symptoms, who was treated by HIFU in our hospital after the first cycle of FOLFIRINOX. 2 days after HIFU, pain was completely relieved. These are transverse contrast-enhanced MR images of treated tumor before HIFU when the CA99 was 648.8 units per milliliter. 1 day after HIFU treated, tumor region shows no contrast enhancement indicative of effective ablation. Considerable regression of tumor volume of 62.6% was achieved 6 weeks after HIFU treatment. CA99 dropped to about half. Further tumor shrinkage with a volume reduction of 90.1% occurred 3 months after HIFU. CA99 dropped to 205.6 units per milliliter. 12 months after HIFU, tumor remission was achieved with a CA99 of only 15.8 units per milliliter. The extent to which patient survival was improved by HIFU therapy remains an open question, especially since no comparison group could be evaluated. However, it can be stated that the results are not worse than after chemotherapy alone, rather they tend to be better. These graphs show overall survival of patients with inoperable pancreatic cancer treated with HIFU. Overall survival time from initial diagnosis was 64% after 12 months, with a median of 13.3 months. Survival time after HIFU intervention was 32% after 12 months, with a median survival of 6 months. After these promising results, let's talk about complications, evaluated here for our first 50 patients. In about half of the patients, we found subcutaneous edema of the ventral abdominal wall, shown here once in computed tomography. This resolved in most cases, but in a few, fatty distension persisted as shown here. About 2/3 of patients reported marked abdominal pain after treatment, which persisted for about 1 day and then improved. Skin burning occurred in 2 patients and regressed within the next 4 weeks. An increase in pancreatic enzymes was seen in 4% of patients, in all without clinical relevance. And thus, we can summarize that with HIFU therapy, an effective and lasting improvement of tumor-related pain is possible in the majority of patients. This independent of the metastasis status. We found a significant reduction in the severity of pain as well as in the pain sensation. Due to this symptom improvement, pain medication could be significantly reduced in most patients. Thus, in about 50% of the patients, pain medication was no longer necessary at all after treatment. HIFU treatment was also possible in patients with biliary drainages. We found a sustained tumor volume reduction in about 80% of patients and, depending on the situation, A second HIFU therapy was also possible in cases of local tumor progression after the first treatment. Improved survival may also be achievable, but this would need to be evaluated by further studies. With this, I thank you for your attention, hope not to have put you all into deep sleep, and I'm available for questions. And of course, this work wouldn't have been possible without Milka Marinova and all of our PhD students. Thank you very much.
Thank you very much. We can either, if there are any questions now, either raise your hand or put it in the chats. Otherwise, we can just have the questions at the end. So maybe I cannot see if there's anybody who wishes to ask a question now, please do. Otherwise, maybe during the presentation, the thing to do is to put the questions in the chat, and then we can discuss it at the end. So I can't see any questions. Oh yes, Mohammed, if you unmute yourself.
Yeah, good afternoon. Welcome. Good afternoon, Dr. David. How are you?
Very well. Very nice to hear you.
Yes, thank you very much. It was very interesting presentation, and with very good relation to our practice. I just have one question related to the biliary stenting. Usually in our practice, we prefer to put metallic stent. I saw in the statistics some patient with plastic stent. What is the situation you faced the doctor to have this, and what is the safety margin to do plastic stent with HIFU?
Yeah, we try to keep away, regardless if it's plastic or if it's metal, because even if it's metal, it may be heated by the HIFU energy. So we try to keep away approximately 1 centimeter. And yes, metal stents would be preferable, but if they have a plastic stent or internal and external drainage catheter, it's plastic too, it's possible, but you should keep away, and we keep away at least 1 centimeter.
So you produce do the procedure with plastic stent?
Yeah, we did.
Yeah. Okay. Okay, because I faced this once, but for my knowledge, I prefer the metallic stent on all patients. So you now changing our practice, and this is great. Thank you very much.
So we have a question from Stephen Chang to, well, to everybody, but maybe you could answer this, Holger. So do we have data on the effect of HIFU independent of chemotherapy? And Professor Kung Zhu says, I think there's evidence of HIFU plus chemotherapy is better than HIFU only, but I just wondered if you have any comments on that.
Yeah, we are trying to do a comparative study with 2 groups, one with chemo only and one chemo plus HIFU. But patient acquisition is more than slow.
Sure.
So we only have, I think, a little bit more than 10 patients during, I don't know, 5 years, something like this. So there are no data.
Yeah.
And there is not, you can only look in the literature and see, but just for practical reasons, we have seen patients, a lot of patients who ask for HIFU, they already have chemo, because usually it's, these are patients from far outside Bonn, and so they show up after first line, second line chemotherapy, and despite chemotherapy, tumor progression and pain, because most are symptomatic. And then we try to do HIFU for symptomatic relief. Of course, we also try to downsize the tumor, but main indication is symptomatic relief, and this works.
Yeah. Thank you very much. So keep typing your questions into the chat. And so this is to speak about the role of HIFU in liver and pancreatic tumors and maybe have some ideas for the future. So it's a great pleasure to speak. Let me just get rid of this lot. Hang on. Okay, so anybody if you're ever in Oxford, you're very welcome here, and we would love to show you our department and our unit. So many people will have heard of William Osler. He was a Canadian who was one of the founding fathers of the Johns Hopkins Hospital in the United States, and he ended up as the Regius Professor of Medicine in Oxford. And he is reputed to have said diseases that harm require treatments that harm less, which is very appropriate for HIFU. And Mencius in China said something similar, that compassion for fellows is a matter of the heart, and righteousness is the path. But of course, surgery has come a long way from open surgery, which is what I spent most of my life doing, big complicated renal surgery, sometimes going up into the heart, to the laparoscopic, to my colleagues who are doing robotic surgery. And I say that I moved from open surgery, and I missed laparoscopic and I missed robotic, and have gone straight to non-invasive. And here again is William Osler in Oxford, standing in his room. He died in 1919. And we were privileged to have Professor Zhang Langling and Professor Lang from the Chinese Medical Association of Obstetricians and Gynecologists in Oxford. And in fact, in 2017, the Chinese Osler Society was founded in Oxford, but is in China now. And Gail Tahar and I had the privilege of going to Tibet a number of years ago, and we saw this, which was very interesting. So this is like the HIFU principle, of course. Sorry, let me just go back. So this is how they boil kettles in Tibet, but using a similar principle to HIFU. And Gail and I had a good time there. And many of you will know this paper, which really is the first one that talked about sound being useful and the effects of high frequency sound waves in 1927. And some of you may know Tintin, and I saw this book in the Calculus Affair where it talked about the power of sound crushing and breaking windows. And of course, we know everybody who works with HIFU knows about the Fry brothers, an interesting name, but the two brothers who really started HIFU work in the 1940s, looking at Parkinson's disease, but they had to open the brain to treat. And then, of course, the drug treatment for Parkinson's overtook that. And this is a rat liver, Gail Tahar showed, and the power of HIFU in just making a hole here in rat liver. And Gail, of course, certainly in this country was one of the, well, worldwide has been one of the leading physicists working on HIFU over many years. And here is a setup that she made in the Royal Marsden in 1996 to treat liver cancer. This was made by her. So this was one of the very early treatments of liver cancer. And in China, as many of you will know, it started in 1997 and the approval came in 1999. Well, in Oxford, we have had contacts with the Chongqing HIFU for the last 20 years. I first went out there in 1999. And this was the purpose-built unit that we had in Oxford in early 2000s, the first purpose-built HIFU unit, I believe, in the Western world, even though it looks as if it's just a fairly small shed. And we had this machine, the JC200 machine, and now, although this, and here is the HIFU center in Chongqing in China, and in Oxford now we have this, the JC200 machine. And this was the first patient who had metastatic liver cancer who was ever treated, I believe, in Europe, certainly with the Chongqing JC machine. She died soon afterwards, but she allowed us, she had multiple mets in the liver, but she allowed us to treat one of her liver tumors, which we then removed post-mortem and saw the effectiveness. And this is the team that we had in the early days: Professor Feng Wu, that many of you will know, David Wild, three of my research fellows, and Val Berry, who is our administrator. So you've seen this. This is, of course, what we are using with a focal length of 12 to 14 centimeters, targeting the liver. And this is a piece of ox liver that Gail Tahar showed me with, as you know, a very fine, very sharp margin of about 6 cells thick between the non-treated liver and the treated liver. So very, very precise. And indeed, as you can see, every time you fire it, you get one of these little things, and how precise it can be in the middle of a block of ox liver that this was used, and just painting out the tumors like this. We've treated quite a lot of things over the years, mainly in clinical trials, but I'm just talking about liver and pancreas today, with some ideas for the future. And this was the paper that we wrote in 2005 in the British Journal of Cancer, looking at the safety and feasibility of HIFU for the treatment of liver, and we looked at kidneys in a Western population, looking primarily at the safety and toxicity, and then secondarily at the performance. And we had 56 patients. In the liver tumors, we had 28 that were treated non-surgically, and then we looked at them radiologically. We had 7 treated surgically that then subsequently had the liver resected, and we looked at histology, similar for the kidney. And these actually were the kidney patients that we treated. And the problem with kidney, unlike liver, is the perinephric fat around the kidney absorbs the HIFU, so it makes it less effective. But anyway, as a result of that, we managed to get the machine CE marked by the European Community for treating liver and kidney tumors, and it's more recently been extended to include all abdominal tumors. And here's James Kennedy, who was one of my first research fellow who set up the whole scheme with me, who now has changed direction and is actually a priest, is the vicar of a nearby church up in Chipping Norton. But it was really James who was responsible through his PhD work in setting up the major link with China and in getting the JC machine approved for use in the Western world, in Europe. He remains a good friend. He remains very interested in what's happening with HIFU, and he's just a few miles north in Oxford. So that was the ablation of the livers. And then a current radiological fellow who's just completing his training did his DPhil on this, which was targeted drug delivery for liver tumors, which is very interesting. So using a focused ultrasound to release doxorubicin, and basically you take doxorubicin, a cytotoxic agent, and you put it into thermosensitive liposomes. These are a little bit like butter. They are stable at 37 degrees centigrade, but they break open at 42 degrees centigrade. So here we are, just that small range. So you get drug release when the temperature hits 42 degrees centigrade. And so you can get basically a very high concentration in a tumor if you manage to heat the tumor up to 42 degrees centigrade. So what my colleague Paul Lian and Konstantin Kousios, who's Professor of Biomedical Engineering in Oxford, did was took patients who had metastatic liver cancer, and you put a slightly non-focused beam, HIFU beam, over the tumor so that you are heating the tumor up to 42 degrees centigrade. And then here, so here, for example, is a tumor in the liver. You take a biopsy of it just to show that it is a malignant tumor, mainly secondaries from colorectal cancer. And then we induce thermodox peripherally into the vein, and then you heat up this particular area, the tumor, to 42 degrees centigrade. And then as the liposomes pass through, they break open and you get targeted drug delivery. So here's the baseline before tumor delivery. Here's where we were heating it up with the ultrasound. And then you see a much increased damage to the tumor, more so than just ordinary drug delivery at 2 weeks and at 4 weeks. And we had 9 patients with complete radiological assessment, and most of those showed significant increase in drug delivery to the tumor with good results. And this was the first study done in man of that, and it was written up in the Lancet Oncology in 2018. So what about pancreatic cancer? We do not have the experience of pancreatic cancer at the moment that Professor Holger Strunk has, but we have treated a few patients and we have some trials ongoing at the moment. So again, we have 2 trials. This is my colleague Paul Lian, who's a very bright young clinician who did his DPhil on the targeted drug delivery for the liver. And as far as pancreas goes, Professor Wu, who's with us, treated in China 8 people with unresectable pancreatic cancer with, again, mainly for pain relief. And you can see the effects here. It's not quite so easy to see with the pancreas, but there is lack of uptake after treatment, and did again put some stents in and treat patients with stents in, and again for palliative treatment. I think this image is reversed because the pancreas is normally on the left-hand side, of course. But and we treated, in the early days, we treated 1 patient in Oxford for pain with a good result and relief of the pain. And we are now starting both an ablation trial of pancreatic cancer and also, similar to the liver's, targeted drug delivery for pancreatic tumors. So what about the future? Be interesting to see what my colleagues think about this, but I think the machines are going to get smaller, the treatment will get faster, the imaging will get better. And one of the interesting things that we are going to look at with the pancreas is, which I think is very exciting, is the possible immunological studies and whether certainly if you have the cavitation and you're breaking up the cells, whether if you release some of the antigens, whether you may get anti-tumor antibodies. And if you do, whether that could possibly have an effect on metastatic disease. I don't know if anybody knows the ongoing work with this, but certainly some time ago in Lyon in France, they were looking at endoscopic probes, and it may be that some of HIFU on endoscopic probes may have a place. This is also interesting. Some people may have heard of Eleanor Stride, who worked with Gail Tahar, a very bright research scientist who's working in Oxford, just running this research centre called Botna 3, and she is interested in HIFU and is looking at the possibility of targeted antibiotic delivery in the same way that you can do targeted drug delivery for deep joint infections that are difficult to treat. This is a colleague of mine, Peter Ratcliffe, who won the Nobel Prize for Medicine with 2 others in 1919 for his work on how cells sense and respond to oxygen. And maybe in the future we will be looking at prevention rather than cure, but I think as long as we're looking at cure, HIFU is going to have a very bright future. And also especially possibly due to COVID, when of course you're not making any incisions, and for a lot of these things you do not need theatre time, even if you need anesthetic time and sedation. So I'll stop sharing there, and thank you very much, and happy to answer any questions now or perhaps later on.
Yep. Are there any questions? I don't see any hand.
Let's move on, and it's a pleasure to introduce Professor Zhu Yonghua, who is Chairman and Professor of the Department of Imaging and Interventional Radiology in Fudan University in Shanghai Clinical Research Center. Sorry?
Continue, please.
Yes, thanks. So he's a board member of the International Society of Minimally Invasive and Virtual Surgery, and associated chairman of the Ultrasonic Therapy and Bioeffects Committee of the Chinese Association of Ultrasound in Medicine and Engineering, and a permanent member of the Mini and Non-Invasive Medicine Committee of Chinese Medical Doctors Association, and involved with the Tumor Ablation Committee of the Shanghai Anti-Cancer Association. He's on the editorial board of the Journal of Interventional Radiology in China and the Chinese Journal of Ultrasound Medicine, and was a member of the European Society of Radiology and the Society of Interventional Radiology. So it's a great pleasure to introduce you, and I'll hand over to you, Professor Zhu Yonghua.
Hi, David. Good morning. Look at my screen. Background is morning. My topic is MR evaluation for Fox ultrasound ablation in treatment liver cancer and pancreatic cancer. I know the mechanism you guys already talk about, and I just show the movie, and it's pretty easy to. Oh, it will not works. Look like it works. Yeah, and from the point to point, and then become line, and line to line, become the slice, and slice to slice become the volume. And we try to completely ablate the tumor, and normally, oh, it works. And we try to increase the temperatures more than 60 degrees. And probably ultrasound cannot see the temperature is more than 60 degrees, but MR can do it. And we first used the MR guide HIFU to do the uterine fibroids. I think it's 30 years ago, which is the first clinical trial in China for MR guided HIFU to ablate the tumor. So now you guys talk so much serious and the clinical trial. I try to show you sharing and real world of our experience and work. First case I'll show you, this is HCC, and which is the tumor located at the right lobe. This guy is 6 years old, and the tumor is nearby the I think nearby the vena cava and the second hepatic portal is large one, and after HIFU we can look at it is almost complete ablated. It's cool. However, other radio frequency ablation can do it. The microwave can do it. Our advantage is non-invasive, so the patient can recover very quickly. And the second day they can discharge and go back to home. That's important. However, this one is a hepatic carcinoma, which is not so, fortunately, after twice tests, still there's the small portion of the necrosis of the tumor. And also this tumor is located difficult position and nearby the vena cava and the portal vein, and the surgeon refused to resect this tumor because of the big risk. And also the 70 years old. And we try to use HIFU to ablate it. Unfortunately, it's not so successful. And we try to think about why we cannot ablate it like the case before, the case one. So we try to change the environment of the tumor. Actually this is tumor texture. We believe the tumor texture will influence the ablation effect of HIFU. So we use the needle. Actually, this needle is very tiny. It's a 12G needle. We call it is non-injured needle. And we inject the iodized oil to change the structure, change the texture of the tumor. And look at the CT scan, we can see a lot of the iodized oil located. And interesting that we after that we perform the HIFU. It's a lot of cavitation happen. But cavitation happen, that means we can see very clearly and under the the ultrasound skin. So look like the uterine fibrosis. If some of the bright become covered all the tumor, that means we already ablated the tumor. So interesting thing that this case is metastatic lesions at the left lobe and the right lobe, and this case is after colon cancer surgery. It's a big one, and actually look like it's more than 7-8 centimeters, and we can completely ablate it. But we not believe the CT scan. Some cases not like exactly true. Look at this is cases from the liver, metastasis from the ovarian cancer. The lesions located at the subcapsule. And after HIFU, and we can see the ablated here. However, we also did the CT scan and cannot see anything. And also this lesion, we not ablated so very well, and CT scan look like pretty good. Actually, this is just like after 1 day and 2 days after the HIFU. So we recommended and follow-up examination is MR scan, conscious MR scan. And this is hepatic metastasis from the colon cancer surgery. We have a lot of this kind of cases because so many, the cases after colon cancer remove, resector. So this guy is a female, 60 years old, and we can see conscious enhanced MRI, and this is before the HIFU. After this ablated and the lesion shrink, and the same thing this one in the T2 weight imaging, and before HIFU and after HIFU. And after HIFU, we can look at is the wall, it's the chest wall and the abdominal wall. It's edema. This is the path of the ultrasound penetrate. This case is also hepatic metastasis from the pancreatic cancer. And this lesion is a small one, and the patient refused to undergo the surgery, and we can look at this ultrasound guide HIFU. It's very clear. So look at this one is liver here and the lesion over there, and after ablated, the HIFU ablated, and almost completed, necrosis. This challenge carcinoma cancer of the liver at the right lobe, it's a big one. This is much malignant. And after we inject the iodized oil and then ablated, almost complete, ablated the tumor. It's pretty easy. Also look at this one. It's look at not so much edema on the path of the ultrasound. And another one is female and 80 years old, HCC on the right lobe, and this is before and after that it's complete. However, this in the edema is much than before. The good thing is the skin is fine, and this is also method from the colon cancer surgery, and the lesion is located between the first and the second hepatic portal. It's nearby the portal vein and also vena cava. It's a difficult location for the surgery, and radiofrequency ablation, also micro ablation as well. And this is middle of, just after HIFU, and we can see all the the brightest in the echo, and this is liver, and this is lesion over there, almost complete ablated, and follow up of the MRI, conscious MRI, and this is the result pretty good. Same thing is this is located in the second hepatic portal, and it's also different case nearby the heart. Okay, also this one also nearby the heart, right? Okay, so we pretty easy heart over there here, and the symbol closer is heart. So look at this is lesion is very difficult, and nobody can treat it. Maybe only chemo, and we can ablate this the difficult location of the hepatic metastasis. This lesion also is difficult in the location. This is after ascending the colon cancer surgery, and the metastasis lesions over here, and we try to operate. Although you look at this image, is pretty, much obvious, and but this apparatus so not so good, but it's fine. And we try to also, this is location is difficult to inject the iodized oil. So we just perform the palliative treatment. So the patient will feel the pain. We try to use the IV anesthesis. It's pretty easy, and the patient can accept this. Patient just a little sleep after, the procedure is quick, recover very quickly. We use two kind of the medicine. This is propofol, and this one is the HCC portal vein tumor thrombosis over here, and also the right branches was invaded, and other surgeon did not like him, and also no other treatment procedure to do it. So we accept this patient and look at this is invaded, the right branch of the portal vein. And this is ultrasound imaging. We can see this portal vein and thrombosis over here, thrombus over here. We just direct hit at the focus, the thrombosis. And the good thing is thrombosis disappeared, and after 1 month of treatment, and look at all the lesions disappear. We follow and for 15 months. Look, it's become normal. Actually, this patient is now survived 3 years. AFP decrease 15, and the other, the anesthesis, IV anesthesis, we use the Pancreatic. It's very safe and also very effective, and the patient recovered very quickly. After the procedure, just like 5 minutes, they can recover, and the patient very happy for this kind of thing. This guy is after sigmoid colon cancer, surgery, and there's hepatic metastasis over here. And we treat it as much high energy. Actually, we use the 400 watt and 2 seconds to when the sonication, and 1 second intervals calling. And we can look at this almost completed. Is ablated. However, there's some of the bleeding look like, but this fine. This patient is fine. It does not feel so pain. I saw something during the procedure, and they discharged. He discharged next days. Until now, it's still no complication. This is, the hepatic metastasis also is after colon cancer surgery, and the patient, the lesion is located second hepatic portal. There's a risk for the radiofrequency because it's the bleeding and the thrombus in the vena cava. So they try to refer to us and use HIFU. After HIFU, look like the vessels still keep intact, and the lesion almost completely ablated, and the lesion also very close to the heart. So it's good thing for HIFU to perform for the challenger cases. Since the radio frequency and the microwave and cannot do it, we can complete the procedure and complete the treatment. this is a bigger one and compared to the other patients. And we can look at these patients already has Barrett's syndrome, and they compress the invade vena cava and invade the portal vein and in hepatic vein. And this is under ultrasound guide. This is the liver over here and the lesion over there. And we injected the iodized the oil and then shoot this sonication. And look at the bright, become bright. And this is after first the ultrasound ablation, focus ultrasound ablation, majority portion of the lesion completed, ablated. Still, there's some at the edge of the lesion, and there's residual tumor. And we performed the second one after 1 month, and the patient refused to underwent the MI. The image becomes, you think, too much cost. Actually, we cannot left the good imaging, but the patient is very good. Also, we try to introduce some of the metastasis not so successful treatment. This is before treatment, and we use the test and look at is lack of the blood supply, and we try to inject either iodized oil and look at this is some of the oil deposit in the lesion, and the CT scan find that this is conscious over there, and after 1 month become large one. So we try to first use the HIFU to ablate the largest one at the left lobe, and this one is for second procedures. The patient feel pain relief and in a good situation after first ultrasound guided focus ultrasound ablation surgery. Also, same thing, this one patient is pain in upper abdominal pain, and the patient is pancreatic cancers, which is already extensive metastasis in the liver. And we tried first ablate is the largest one and nearby the stomach and the small bowel. This is nearby the gastrointestinal tract. It's we afraid of injury the tract, and the ultrasound ablation, focus ultrasound ablation can avoid this risk. It's pretty good that we can keep it a safe age. And next one we can try to ablate other ones. This is actually palliative treatment. We try to reduce the tumor size and to increase life times, and also is improve the quality of life. This ones cannot do this intrahepatic, the metastasis from the liver cancer, and the lesion is located is the abdominal cavity, and we try to use high intensity focus ultrasound with much high energy. Still look like edemas on the the right abdominal wall is becomes very thick, and after treatment we can see it's only 100% in the portion of the lesion ablated. It's fine. We try to keep the tumor size down. Second one, we can introduce the treatment of the pancreatic cancer. And this is the images we have performed the ultrasound guide. This is the IOT. This is, celiac chunk, and this is tumor, pancreas tumor, and this is liver. So our colleague in the Shanghai, they saw this image. They think it's pretty good and it's easy to show the pancreas, structure and the tumor structure. And the same thing, we can ablate the tumor from the point to line to slice and to volume. Okay, this patient's before treatment, which is pancreas head cancer. And we try to use this path of the ultrasound to penetrate the skin. However, look at this, so many, the bowel and the stomach are also nearby. So we try to use some of the gel in the intake, and then can that this small bowel has some of the gel over here, and then we use this path and penetrate it. Okay, it's fine. And after treatment, we can see the tumor, majority tumor is lack of blood supply. It look like it is less perfused. So sometimes we use the conscious ultrasound to monitor the ablated area. However, look like here is very clear, but most of the situation, I believe conscious enhanced ultrasound cannot see very well. Only MR image you can see is very clear ablating area. And this is before HIFU and after HIFU, and can see this ablating area is pretty good. And also the CA 199 indicates very quickly. So same thing is MI. If we use the T1 with imaging and the T2 with imaging, and we can see the lesion, but we not sure how much ablated percentage. But we use the conscious enhanced, we can see very well in the ablated area. And compare the CT scan, we will show it. And this is a CT scan. We can see the metal stand in the common bile duct, and we say clear. However, the MR, we cannot see it. This is the before the treatment, and we can see the tumor already invaded the vessels, and after treatment, the vessels still keep intact, and the tumor already ablated. So this is before treatment, and this is pancreatic neck cancers after 2 months, and we see this ablated area, and the tumor shrink. So this slide, so I show you why we do not use CT scan for follow-up after HIFU treatment. This is advanced cancer at the pancreatic neck. And before HIFU, look at this is the tumor over there, and after treatment, we see not so very well. And MR, we see this is cleared ablation area. So we recommend the MR is better than CT for follow-up. This case, unfortunately, the patient died 10 days ago. The patient is almost treatment 1 year, is a big one. And after treatment, the tumor shrink and also ablation areas is become small. This pancreatic cancer is a very, very tough cancer. Even when treated very well from the imaging, however, the patient not feel pain, but exhaust for the body, because they always take some medicine, chemo, and become weak and weak. We cannot stop the give her in the chemo because they think the physician think which the comprehensive treatment. So that's, we do not know how to get a good approach for treatment the pancreas cancer. Since from image, the tumors become almost ablate very well, and the size becomes small, the patient die. So this case, I think is Dr. Zhang Lian and with Dr. Milk and performed in Germany, and the tumors look like it's become smaller and ablate very well. However, I'm not sure that, how long the patient survive. That's our question. We need to know not only improve the quality of life, also we want to know how much time will that patient survive. So as a whole, I think pancreatic cancer, we use the HIFU treatment is feasible and treatment, it is effective and also safety. That's, we treated the pancreatic cancer and the liver cancer, there's no complication. Actually tell you that the complication is less than HIFU treatment uterine fibroids. In the year before last year, we performed the first one, 5G back the remote control, HIFU. That's, we think that if we have the 5G everywhere, we can perform the remote surgery by HIFU. Thank you. Thank you for your attention.
Thank you very much indeed. Just before we move on, there are a couple of interesting questions on the chat, and I just wondered if you have any comments about that, about the ablating tumors near blood vessels and how close do you go? And I think Professor Zhu was replying to it, but is there any danger ever of perforating the blood vessel?
Actually, I tell you that we shoot the vessel cannot injure it. That's our, so much, the advantages to HIFU. And we just, for example, we can treat the thrombus, the portal vein, in portal vein by HIFU. There's no injury, even the vena cava and the hepatic vein, also in the vessel, you cannot, injure it.
Oh,
that's, yeah.
Thank you very much. I'll hand over to Holger.
Yeah, let me comment on this danger for the vessels. In most cases, there is no danger. However, if there is tumor encasement, and we are very, very careful not to shoot on the vessel directly. And we are very careful to stay a little bit away from the vessels, because we have seen patients getting some edema in the tumor after therapy. And this edema was enough to occlude the vessel. In most patients, this goes away. But in some patients, let's suppose it's a SMA, superior mesenteric artery narrowed by the tumor encasement. So if this vessel will get occluded, you will get bowel ischemia, and no surgeon will save this patient. So I would say there is not a risk of bleeding, but there's a risk of occlusion of arteries or veins due to tumor edema.
Yeah, you see it, what kind of tumor? Actually, what kind of, for example?
Pancreatic. I don't care about. I don't care about liver vessels.
I just talk about the liver. Yeah, liver, pancreatic. I don't know. Not so much. The energy to give, because there's some small bowel and the stomach over there, and we're not shooting the arterial. Actually, I talk about the vena cava, hepatical vein, also portal vein. It does not
Okay.
matter.
Yeah, there I think it's no need to stay away.
Okay.
Any more questions? I haven't read the chat, so maybe I should have a look on this. Or Jenny, do you follow for
There's nothing else on the chat, I don't think.
questions? Okay.
Yeah.
So yes, we then can move on to the last lecture. It's Professor Xu Qin, a friend of mine, one of my teacher. So now the teacher, hi. So Professor Qin is he's from Second Affiliated Hospital of Chongqing Medical University, and he's an associate professor. And his clinical applications of high-intensity focused ultrasound, clinical oncology, and basic and clinical research of HIFU. In 2020, he awarded the, I don't know how to pronounce correctly, Quanwen Talents Program of the Second Affiliated Hospital of Chongqing Medical University. So Qin, I'm very interested in your video. I think you will show a video about surgery video HIFU treatment for pancreatic cancer. Please go ahead.
Thank you, Mr. Chair, Professor Cranston and Professor Strunk. Thank you, everyone. And now in China, it's very late. It's 9:30 p.m. So I will try my best to speed up. Well, can you see the PPT here?
Yes, great.
Okay. So our hospital was founded almost 130 years ago. So this is the historic picture of our hospital. And this is the HIFU team of us, the Second Affiliated Hospital of Chongqing Medical University. Well, also the national training base for HIFU treatment was founded in our hospital since September 2005. It's over almost over 15 years. During last 20 years, there are over 500 doctors trained in our center. They are from 120 clinics or hospitals or university. See these pictures? Well, personally, I have the experience of HIFU treatment for the tumors or the lesions or the diseases from the head and to the chest wall, metastasis on the chest wall, in breast cancer, in liver, in pancreas, in kidney. This case from PISA, Professor Candio. And uterus. Also happened on the legs, adrenal glands, and the bones. Inside the abdominal wall, and even on the bottom of the feet. So we can say the candidates for HIFU treatment could be from head to feet. So as we all know, the heat delivered by the ultrasound could ablate or treat those solid tumors. Also, we have the two clinical guidelines in China. The first one was published in 2005, and the second was published last year. Also, we have another guidelines in the Fudan University Shanghai Cancer Center. So here in China, we can gather the evidences and the experience of HIFU treatment for pancreatic cancer. This article was from Fudan University, Shanghai Cancer Center, including over 400 cases accepted HIFU treatment. And it was found that the HIFU treatment provide the survival benefits for the patient. Also, the experience from the surgeon leads us to that if we perform the HIFU treatment as a pre-operative treatment before opening surgery for those patients with borderline resectable pancreatic cancer, it is possible to improve the possibility of the R0 or R1 resection. So compared with those patients accepted RT radiation therapy, this data from MD Anderson Cancer Center, it was only around 40%. That means the HIFU treatment probably provide a better opportunity for patients with the borderline resectable pancreatic cancer to accept the future R0 resection. Also, we found that if we perform the HIFU plus chemo together, that means a local HIFU ablation plus a systemic medicine therapy, it will give more longer survival for the patients. So in our center, at the very beginning, it was just a palliative treatment. The first, the initial target from us, it is just a local and partial ablation for the patient, and or try to control or release the pain. But during these years, we found that there are evidences of benefits for survival and benefits for the pain control or release, and the benefit to improve the quality of life for this patient with pancreatic cancer. Well, I have to quit to the video. Is it clear? This is the operation room in our center. We can see the patient table is on the center of the room.
Quinn, you are back to the whatever mode, but we don't see the video.
I will quit and
okay.
One.
Just to let you know. Okay, now it's
the
video.
Okay, again, started. So this is the HIFU room of our center. We can say the patient table is in the center of the room. The patient is in prone position. Well, here, we can stop here. We can see this is a metal frame here, and with the pillow belt to hold the patient here and closer. Okay, stop here. There is a point that I want to emphasize that with the prone position, we should make sure the free of the joints here. The shoulder and the elbow joints there. We say that all joints free during the HIFU treatment because the ultrasound guided HIFU treatment is from the lower part. Transducer is inside this tank. The transducer is here. So the therapeutic ultrasound is from the lower part to the upper part, from this direction, from lower to upper. so that for this patient, it is in prone position, we should make sure all joints free to avoid such the muscle or the nerve injury during the treatment. Well, go on. And then this patient is under the general anesthesia. See here, the shoulder, the elbow, the joints free. Well, it's under general anesthesia, and the Professor Yonghua Xu said it is possible to perform the HIFU treatment for pancreatic cancer under sedation. Yes, it is. In our center, the ratio is about 2 to 1. 2 patients with pancreatic cancer accepted general anesthesia. The one accepted deep sedation. It depends on the situation for the patients and the purpose of our operation. Yeah. Well, this is the chief doctor for this operation. This is the workshop, say here. And this is ultrasound image, the real-time monitoring beam mode ultrasound. And this one is the image before treatment with the image helped real-time ultrasound guided therapy. It is possible to find all the details during treatment. Well, let's go back to the PPT again. Here, I would like to share a video during from one case. Here, we can see the right part is the patient. The tumor is on the body of the pancreas, and it invade the blood vessels was included by the tumor from here. See, this is spine, and this is aorta, and this is celiac trunk here. This is the body of the pancreas, and we can see the tumor is here. This video is before treatment. Okay, let's see it. It's under the CUS, the contrast enhanced ultrasound image with the solar view injection. We can see here enhancement here. So the microbubble enters to the blood vessels first, and the less bubble enters to the tumor. So generally speaking, the pancreatic cancer is a poor blood supply tumor. See, the aorta strong enhanced, but the tumor was poorly enhanced. Well, let's jump to the treatment here. Let's say the hypothetical change will happen here. The same precision, the therapeutic, the invisible ultrasound from the lower part, from the transducer here, and focused on here. Each solicitation got a hypothetical change. We call this a massive grayscale change. it's larger and larger. Okay, speed up. Another point here. Another massive green scale change. So with these solidifications, one dot by one dot, we will place the focus for where we want to treat or where we want to ablate, and finally complete the treatment plan. Well, after that, we perform another CUS with solo view, again to see what happened to the tumor. Almost no enhancement happened here. Well, this is the videos. Well, another case is here, just treated last week. This case, this gentleman was diagnosed on this May. There was pain happened on the belly and the back. The C99 is over 1,000. So after diagnosis, the chemotherapy was performed 6 months. The C99, it was 500 on 1 month ago. And here, the tumor size was smaller than the very beginning. And yesterday, the rescan after hypothermia, we see that the tumor was ablated successfully, and the C99 is only 265. This case was 2 hours ago. We accepted this lady. It was a very huge one with calcification inside, and even with a blood vessel. This is SMA here, a blood vessel here. So after treatment, we can say that it was almost complete ablated, and the blood vessel was safe, no any change. It's here. So generally speaking, we believe that based on the clinical reports and from our experiences, we believe that first, the HIFU treatment will benefit patients with pancreatic cancer for survival. So far, we found that the median survival time was 12 to 24 months. The second one is that it will help us, doctors, to control or release the cancer-related pain for those patients. The third is that it is possible to be a pre-surgery for borderline resectable ones. I believe the surgeons will like this idea to use this non-invasive treatment to help them to change the stage of the patient and perform a R0 resection for pancreatic cancer. Also, there is strong evidence that the HIFU treatment will improve the quality of life for patients with pancreatic cancer. So finally, we believe it is a safe and a minimal invasive treatment. Well, this is what I want to share you. Thank you. And dank. And grazie. Thanks.
Great. Great. Thank you very much.
Thank you, Professor.
So, any questions? Interesting lecture. Thank you very much. Are there questions? Anything in the chat? I don't see any questions. Any hands up? No? Okay. So in Germany, it's only early afternoon, so no need to hurry.
The same in Oxford. Even earlier.
No hurry to go here.
Oh, that's good. Great. So, yes. So if there are no questions, no comments any longer, David, anything you want to mention?
No, I think we've had some interesting questions. The most interesting one, which you were very helpful with, was my concern about treating near large vessels, but what you said was very helpful, so thank you.
Okay. Professor Zhang, you still there? Do you want to comment? Or the organizer?
Yes, I'm here. So you guys just did a wonderful job. So I enjoy this meeting. So how about see you soon in China or either in Germany or UK?
Yeah, I would appreciate. So it's already nice to see you after this long period. It's more than 1.5 years. So I don't know if this pandemic will stop. So I guess now for everybody going to the Far East, from our viewpoint, will not be possible in the near future. Hopefully it will. Yes, I'm looking every month. I'm looking in the regulations to see if it's possible again.
Yeah.
But,
well,
I'm sure.
I hope sometime next year, maybe the middle of next year.
I would be happy. So then, otherwise, I will thank everybody, and maybe see you again for the second part of this webinar.
Yeah. Thank you very much. Yes, thank you very much. Will be unable to join the second part as I'm away, but it's been very good to join the first part.
Yeah. So then, have a nice evening, nice afternoon, and hopefully see you soon.